Good afternoon, everyone, and welcome to the talk on HIV and long COVID. These are my few disclosures. A quick roadmap on the talk. We will look at the definitions of long COVID, whether long COVID is a myth or actually exists. We'll look at the pathophysiology. We'll touch on the risk factors. We'll look at the clinical presentation, management of long COVID, and discuss the research gaps. So the WHO fact sheet defines long COVID as the continuation or development of new symptoms 3 months after the initial infection. And these symptoms persist for at least 2 months or more with no other explanation. There's growing recognition that long COVID occurs in children, and teenagers or adolescents are affected quite a lot. Now, long COVID is a complex disease. It's heterogeneous and multiple organ systems are affected. Currently, we have over 200 symptoms that have been identified. Please note that the severity differs from person to person, and even some patients report different severities of the same symptoms. Sometimes they are worse, sometimes they feel that they have improved. It's estimated that 10 to 20% of people with COVID may go on to develop long COVID. The last stats that I saw from Davis last year in 2023 estimated that over 65 million people worldwide are affected by long COVID. We must note that there's quite limited data, and most of the data that has been presented is from America and Europe. Now, if we look at the long-term effects of long COVID, it's quite multi-system organ, as I said. Just to mention that some people are still using old terms such as post-COVID conditions, long-haul COVID, chronic COVID, post-COVID-19 syndrome. But for the purposes of this talk, we will stick to the term long COVID. So if you look, the most common symptoms are fatigue, which accounts for about 58% of the cases. People complain of headaches. There is brain fog that I know that most people who had COVID usually present with. There's usually quite a lot of chest symptoms. People present with dyspnea, they present with polypnea, they present with cough and chest pain. There's also quite a lot of reported hair loss and the loss of sense of taste, as well as the loss of sense of smell. Now, this list is not exhaustive. It looks like it is growing, but almost all organs are affected by long COVID. A brief touch on the risk factors. The literature seems to suggest that if you are a female and older, you are more likely to develop long COVID. Those with comorbidities such as type 2 diabetes, obesity, chronic kidney disease, quite a lot of chronic chest diseases, heart disease, connective tissue disease, those are more likely to develop long COVID. There's also a link with smoking, with being Hispanic, coming from a low socioeconomic environment. The severity of acute disease, especially those who are hospitalized or landed up in ICU, there's a link with the development of long COVID. Also, lack of rest after the acute infection has been linked with the development of long COVID. The persistence of viral proteins, which we will touch on when we look at the pathogenesis, and vaccines have been shown to show some protection, but there's a study that said that vaccines do not show any difference. And there's also a risk if you have had reinfections, you have a higher chance of developing long COVID. So the summary is that repeated infections could equal in more long COVID, and severity also can be correlated with long COVID. Now, on to the pathophysiology. The scholars seem to think that the mechanisms are unclear. So while we are trying to figure out the mechanisms of long COVID, the question is, does it really matter if we know what the mechanisms are. I think it does, because we need to understand whether it is a viral consequence or it is a post-pandemic consequence, a consequence of the lockdown, that people were shut off from their families, the extreme devastation that some families experienced with a passing of loved ones. We need to understand whether it is related to the virus itself or just a post-pandemic consequence. I also think we need to understand the pathophysiology, because there are consequences for the health system, and this could be quite significant. But whether or not we understand whether the mechanisms what the mechanisms are, I think it's important to understand that because we don't know, it does not mean long COVID does not exist. We need to start to acknowledge that long COVID is there, that patients are not making up symptoms. They are actually going through something that we might not be able to explain. What is compounding this is that the psychological diagnostic tests that we usually use usually come back as normal. There's currently no objective test as yet for long COVID. And even if we are then able to tease out the pathophysiology, we don't even know whether drugs will be able to work. What we know at this moment is that it's a multifactorial disease, and therefore it needs a multidisciplinary approach when we are tackling long COVID. So some of the hypotheses that have been given are that the uniqueness of the immune responses to SARS-CoV-2 could lead to long COVID. There's also the evidence that our immune responses differ, and so children present differently to adults. And the current hypothesis is that at the current moment, there's about 4 hypotheses that seem to be agreed upon. The first one is viral persistence, where we are looking at the viral RNA, the viral proteins, and continual, or what we would call a continuous infection. The second one is chronic inflammation, which leads to tissue dysfunction. And this chronic infection then causes the symptoms of long COVID. We also think that it could be that it's autoimmunity triggered by the infection itself. So the viral products trigger an autoimmune reaction, which then presents with the symptoms. And the last one is that it's inflammation that triggers the tissue dysfunction and the damage. Whatever the case, we do know that it is probably an inflammatory process, and viral persistence plays a role. Now, each of these hypotheses may affect different groups of people, have different preventions, diagnostic strategies. So it's important for us to get it right if we are to tackle the causes and manage long COVID appropriately. This is just a schematic diagram of the 4 things that I listed, that the first one would be the issue of viral persistence. The second one would be the autoimmunity that is triggered by the infection itself. The third one would be the latent virus reactivation and the inflammation that triggers the tissue damage and the tissue dysfunction. Coming to the topic at hand now, HIV and long COVID. There has been quite a lot of talk, and some articles have been published, that people living with HIV seemingly have an increased risk of developing long COVID. We are not quite sure why, and I will discuss some of the hypotheses in the slides that are to follow. But there's quite a few articles that say that the risk is not correlated with CD4 or viral load at the time of infection, although the latest articles seem to think that there is a link. The other problem that we have amongst people living with HIV is that some of these symptoms that people present with could be attributed to antiretroviral therapy side effects. They could be attributed to comorbid conditions or psychosocial conditions. So it sort of makes it more difficult to tease out if there could be other causes for the symptoms. And there's quite a lot of data from, okay, it's limited, but most of the data on people living with HIV is from Europe and America, and I have not really come across any data amongst people in the African context. I will mention at this point that our team in our unit have just completed data collection for a cross-sectional observational study that's set to characterize long COVID in an urban sample of South African adults. We are going to hopefully publish and contribute to data from the African context. But if we look at the pathophysiology and the hypothesis around why people living with HIV would be more prone to develop long COVID, the first thing is that people living with HIV have higher levels of inflammation. And if inflammation triggers the chronic changes that lead to tissue dysfunction and tissue damage, then people with HIV, because they already have higher levels of inflammation, are more likely prone to that effect of inflammation. The other hypothesis is that the virus binds to the ACE2 receptors in human cells, and by so doing, it activates the renin-angiotensin pathways. And these activations could lead to increased frequency of cardiovascular events in people living with HIV. How fair or how sure we are not. Then the viral persistence that we've already mentioned for all people seems to also play a role in HIV, in the link between HIV and long COVID. Endothelial dysfunction, which is exacerbated by the virus, could also lead to higher rates of post-COVID cardiovascular events in people living with HIV. There's been a theory about the leaky gut because of microbial translocation, but we are still not sure if these would exacerbate long COVID pathways for people living with HIV. The Epstein-Barr virus reactivation has also been linked to be one of the things that could lead to long COVID in people with HIV. With HIV, the one thing that we know for sure is that chronic comorbid conditions, the socio-economic factors play quite a big role because people do not necessarily have access to healthcare. And we also know that low cortisol levels in people living with HIV could play a role in the pathogenesis of long COVID amongst those with HIV. But as I said, these are all hypotheses and they need to be confirmed. Now, the WHO in September of 2022 partnered with quite a few long COVID Europe groups, and they came with the 3 Rs. And I'm mentioning these because these are key to us trying to determine the pathophysiology and the management of people living with long COVID. The first one is that we need to recognize and share knowledge around the topic of long COVID and ensure that our services are adequately equipped. Our services should be prepared, should be capable to deal with long COVID, and should recognize that this could actually be a debilitating condition. Number 2, we need to work on research and report the cases of long COVID. We need well-coordinated and inclusive research, and we should also be able to quantify the costs of living with long COVID. The third R is the rehabilitation that is evidence-based, that is effective, and that is safe for both our patients and our carers. Now, coming to patient management. Because we don't know what causes long COVID, we will not necessarily at this moment have drugs to treat long COVID. But the first thing that we can do as healthcare workers or as people that manage patients with long COVID is to believe them. We need to start to acknowledge their symptoms and know that their symptoms may evolve over time. There's system multiplicity and symptom severity that varies from person to person. And we should strive to at least give symptom relief with the resources that we have at hand. It's also a multidisciplinary approach, like I have mentioned. So it's quite important to refer if, for instance, there is immunology that's affected, joints that are affected. It's important to refer. But having said that, the vast majority of our people, especially within the African continent, might not have the resources available to them. And even those with the resources, they might not be beneficial to all. There's quite a good review that I've linked on the slide of COVID management, especially around pain syndromes, which are your headaches, your joint pains, and all of that. It's a good link that sort of gives an idea on how to manage that. And then the WHO gives quite a lot of information on self-management resources, some of which I have listed in this slide. The rehabilitation and the self-management amongst adolescents and how to support the rehabilitation of people living with long COVID. With that slide, I would like to thank you all for listening, and we welcome any questions that come through. Thank you.